Scott Craig, one of the EMT instructors here. I've got Jason Parker to be my patient. I've got Sean Biggs here to assist me. We're going to walk you guys through basically how the assessment of an alert medical patient would go from start to finish, including the administration of a medication. So of course the first thing that I want to do anytime that I'm doing a patient assessment is to assure that my scene is safe. So I kind of want to size up the scene, make sure that I've got all the proper body substance isolation that I might need. That may just be gloves. It may be significantly more than that depending upon the situation. After I've determined that my scene is safe, the next thing that I want to do is to try to get some ideas to the number of patients that I might have in this particular situation. This being a medical patient, I'm going to assume that I only have one. I'm also going to try to make the determination as I arrive on scene whether or not it's medical or trauma based upon the presentation. So if I pulled up to a wreck on a highway, I might assume that it was a traumatic situation. But if I pull up to a house, in the middle of the day, I'm probably going to more assume that it's a medical patient that we're dealing with. I'd also want to order any additional resources that I might need in order to help with this situation. This is going to depend some on dispatch information, also on the number of patients, so that's why I want to keep track of all that stuff and then order the resources that are necessary. It's critical to get those things moving as quickly as possible because, as we get further and further into our assessment, we may determine that our patient's in a lot of trouble. We want to have, all the hands that we might need to help deal with this situation. So after I've arrived and I've ensured all of that has been taken care of, the next thing that I want to do before I actually get to the side of my patient is to determine what we call our general impression. And the general impression is generally just an idea of kind of my patient's condition based upon the things that I can see, things that I can hear, sometimes things that I can smell, never taste on an EMS call scene, but use the rest of your senses in order to help determine the severity of my patient's condition. And so one of the first things I want to look at is age and sex for our particular patient. I'm really concerned about this as far as, elderly patients are going to have different conditions than younger patients might have. Men are going to have significantly different conditions than women may have. So I want to make just a quick determination of the approximate age and sex of my patient. So I've got Jason here. He appears to be, about a 30-year-old male. After that, I want to see if I have any audible breath sounds. I want to kind of take a listen around and see if I can hear Jason's breathing. If I can hear it without a stethoscope, that just suggests to me that his breathing is significantly, distressed. After that, I want to make sure that I kind of take another look at the mechanism of injury or nature of illness thing. That's how we determine the difference between a medical or trauma. Again, Jason is sitting here in a chair, appears to be alert, and so it's a fairly safe assumption that we're dealing with a medical condition. I want to take a quick look around and see if I see any bodily fluids as I attempt to approach him. I don't see any, profuse sweating. I don't see any obvious bleeding, anything that I would need to immediately deal with if I came into contact with. Need to also determine if there's any imminent life threats. I mentioned the bleeding thing. If Jason has a large amount of blood coming out of his body, that's going to be my top priority as I approach him. If I have arterial bleeding where it's spurting out of a wound, I'd want to quickly get to that and make sure that I stop that as quickly as possible because the rest of my assessment may not matter if I can't get that bleeding under control very, very quickly. Some other things that might be imminent life threats, I may notice that Jason's on the floor. He's not moving, not breathing, so it may suggest he's in cardiac arrest. Again, a thing that I need to immediately deal with as opposed to the continuation of my patient assessment. After that, I want to take just a quick look at his responsiveness. Keep in mind, this is an alert medical patient. As I approach or, as I walk up to them, as I enter their home, they should be aware of my presence. They should turn their head towards me. He should have his eyes open, and he does meet all of that particular criteria. And just kind of some other things that I want to take a quick look at is his position. As I mentioned, Jason's sitting in a chair right here. By the way, we got dispatched for chest pain on this particular medical assessment. So I may notice him clutching his chest. I may notice, some indication that he is suffering from a significant amount of pain. Again, if it was a trauma patient, I may find them at, the bottom of a set of stairs, or somewhere on the ground. Again, just helps us to determine what exactly we're dealing with in this particular situation. And lastly, I want to take a look at his color. We assume most of our patients are going to be pink. That just means that their blood is flowing, that they're perfusing. And so I may notice Jason might be pale due to his chest pain. If a patient's struggling to breathe, it may be cyanosis or one of those other things. So as I go through that, and again, I'm just going to kind of sum that up as I would during your guys' patient assessment. So, the things that we're going to do for the general impression, I'm just going to do for Jason right now. So I've got an approximately 31-year-old male. I don't hear any audible breath sounds. It does appear to be a nature of illness as opposed to a mechanism of injury. I don't seem to see any significant imminent life threats to Jason. He is responsive. He is tracking me around the room. He is seated in a chair, and his color at this time does appear to be pink. So these are all the things that need to be done before we approach our patient. As we approach our patient, the first and most critical thing for EMS providers to do, especially when we're dealing with a medical patient here, is to simply introduce ourselves to our patient. So, hi, my name's Scott. I'm an EMT. What seems to be the problem today?
Just having some chest pain.
Okay, having some chest pain. Well, listen, Jason, I'm going to ask you a couple of questions real quick just to kind of make sure that, that you're with it, all right?
Okay.
You tell me what the day is today, what day of the week it is?
Today's Friday.
Okay, and can you tell me where we are right now?
We're at Johnson County Community College.
Okay, and Jason, what's your last name?
Parker.
Okay, and what made your chest pain come on? What were you doing when this started?
I was working out when I got home from work.
Okay, all right. I'm just going to take a quick look. I'm going to check a couple of things out, just kind of make sure you're okay. Can you open your mouth for me? All right, just take a look in Jason's airway, make sure that there's nothing occluding it, make sure there's nothing that may potentially be occluding it. Can you take a deep breath for me, Jason? Go ahead and put my hands on his chest here, just make sure that he has some bilateral chest rise. Does it hurt anymore when you take a breath?
No.
Okay. I'm going to have Sean come in here. And Sean, why don't you go ahead and put some SpO2 on this patient. Since it is a potential chest pain, we got something dealing with the core of the body. Always good to kind of get some of this information as quickly as possible. Jason, I'm going to just kind of feel your pulses here real quick. Just find out if they're present and they're equal. May make a note of whether they're fast or slow, but this is not necessarily the time for us to go ahead and measure that or count that out. Okay? After that, I do want to take just kind of a quick check and make sure that all the places I can't see. Jason, I'm just going to kind of feel behind you here, just make sure that we don't have any blood or anything like that, okay? Any sweating or anything. Like I said, just make sure I'm taking a look at my hands so I know where any blood or any sweat or any other bodily fluid might be coming from. Okay, and I don't seem to find any of that. Now, Jason, real quick, I'm just going to kind of feel your temperature. Again, not a time to necessarily measure it, just trying to get a quick idea of whether he's warm, as we would expect him to be, or potentially cold or hot. Okay. 96. All right, we got a 96% SpO2. Okay. And I've gone ahead and I've assessed his airway, his breathing, and his circulation. Now I need to make an educated decision on how to administer oxygen to this patient. With Jason being a chest pain patient, his oxygen saturation about 96%. It is something that I would consider or monitor and keep an eye on, so I'll leave that SpO2 on there. But for right now, for this particular patient, I'm not going to administer oxygen. And your instructors will get into a little bit about why that's the case as you guys go throughout your training program. So after I've kind of done all those things, I've checked kind of the core or the important aspects of Jason's physiology. I've checked his brain. I asked him some questions just to make sure that his level of consciousness was okay. Checked his airway, his breathing, his circulation. After I've got this information, what I want to do now is to determine a priority. And because Jason is having some significant chest pain, I would have ordered an ALS unit a little bit earlier. Your advanced level providers can do a lot more for your chest pain patients. They can help to diagnose potential heart attacks, potential conditions. So I would have got them moving, and simply the fact that he has chest pain is going to make him a high priority patient for me at this time. And at the EMT level, it's go ahead and it's fairly safe to say if I suspect that Jason is in fact having a cardiac related incident that I probably want to go ahead and triage him red at this time. So I'm going to triage him red, let all incoming units know that that's the case, and I'm going to continue through the rest of my patient assessment. Now, because he is alert and oriented and answering my questions at this time, it's important for me to start out with some of the history questions that we associate with our medical patients. So, Jason, I'm going to ask you some questions just about your medical history, okay? And really what I'm trying to get at is just kind of some situations you may have had in the past. But my first question is, other than your chest pain, are you having any other symptoms? You feel dizzy or lightheaded? Anything along those lines?
Maybe just a little lightheaded, but that's it.
Okay. And it's something we would expect to be associated with Jason's chest pain. And so after that, I'm going to kind of start through his potential medical history. So Jason, are you allergic to any medications?
No.
Okay. Do you currently take or are you prescribed any medications?
I take nitro.
Okay. And now, do you take any herbal supplements, any over-the-counter medications, anything along those lines?
No.
Okay. And Jason, you seem like a nice guy, but I got to ask, any illicit drugs or anything like that that you use? Okay, fair enough. Now tell me a little bit about your past medical history. And when I ask about your medical history, some specific things that I want to know about. Any history of heart problems?
I had a heart attack about a year ago.
Okay, heart attack about a year ago. Now, does this feel similar to your previous heart attacks?
Yes.
Okay, and so, you telling me that just kind of suggests that this may be what's happening again. So I just want you to be aware of that, all right?
Okay.
Got any lung problems, any breathing problems?
No.
Emphysema, COPD, asthma, nothing along those lines?
Nope.
Okay. I got any history of hypertension, high blood pressure, anything like that? Okay, a little history of hypertension. How about stroke? Ever had a stroke?
No.
Seizure disorder?
Nope.
Okay. Diabetes, anything along those lines? Okay. And so again, I'm kind of focused on those three things around Jason's kind of core, physiology. Again, his central nervous system, his cardiovascular system, and his respiratory system. So, always good to ask about anything else. Had anything else happen here recently? No other medical conditions? No major surgeries? Anything along those lines?
No.
Okay. Well, this is going to kind of seem weird, but I do need to ask you, when was the last time you had something to eat?
I had breakfast.
Okay. How long ago was that?
About an hour.
All right. And then what did you say you were doing when this started? Were you doing any physical activity, anything
I
like
was
that?
just working out.
Just working out when that happened, right? And again, this can give me some ideas to the severity of his condition. If it starts while he's working out, I know he was exerting himself a little bit, a little more likely for his chest pain to start. So I've got kind of a good baseline as far as his past medical history goes. Now what I want to do is to ask him some questions about, what's going on with this current situation. We call it a history of present illness, or OPQRST. So, Jason, when did this start?
About 20 minutes ago.
About 20 minutes ago, okay? And does anything make it better or worse? Anything simple, like getting up, moving around? Did it get better when you sat down?
Yes, when I stopped working out, it got better.
And I need to ask you, did you take any of your nitro by any chance?
Not yet.
Okay. And can you tell me what it feels like? Can you describe it to me in your own
It
words?
just feels like a crushing pain.
Okay. And where is your pain? I assume with you guarding right there, it's kind of located right there.
Here in the center area.
Now, does it go anywhere else in your body? Can you feel it anywhere else?
It kind of goes to my left side.
Radiates a little bit down to that left side, okay? And on a scale of 0 to 10, right, 10 being the worst, 0 being the least pain you've ever experienced, can you rate it for me?
Right now it's about a 6.
About a 6. And now you said last time when you had a heart attack, this pain was very, very similar.
Yes.
How would you rate that compared to this time? You said now it's a 6. Last time it was about the same?
Yes.
Okay. Okay. Again, just further information, we may be dealing with a repeat situation of what you had last time. And then over time, has it gotten better or worse? I'm kind of looking to see, is it trending? Is it getting better, getting worse?
It's gotten a little better since I stopped exerting myself.
Okay. And you said you didn't take any of your nitroglycerin?
Not yet.
Okay. Can I ask why?
I just haven't.
Well, fair enough. All right. You waited for us to get
Yes.
here. Okay. And now you said you were a little bit lightheaded or anything like that, and you denied that you had any difficulty breathing.
Just a little bit,
Just
but
a little
not
bit
much.
of difficulty breathing. Okay, all right. So that can still kind of be an associated symptom. Did you have a syncopal episode? What I mean by that is, did you faint or anything along those lines?
No.
Okay. And so what I'm looking for now is what we call some pertinent negatives, trying to determine whether or not there are some things I would expect Jason to have, that he does in fact deny. So, the syncopal episode is something common associated with chest pain. The fact that he doesn't have it, just kind of helps to narrow down my differential diagnosis a little bit. Right? So I've gotten through all of the questions I'm going to ask you, at least for right now. And I'm going to have Sean come in here, and Sean's going to do some kind of vital signs while I go ahead and do a physical assessment. So we'll talk to you guys about vital signs in a subsequent video. And so Sean's going to just kind of go through and get those vital signs while I'm working on just kind of a physical exam of areas where I think I might need to check on Jason. Now, because this is an area involving his chest, what I'm going to focus on is those things that are kind of closest to it. So I'm really going to kind of start out at the neck here. Again, I'm taking a look at his face and everything else. If I see something there that I don't like, I'd certainly assess that. But my primary focus is to just kind of take a look at his neck and see first off if he has any jugular vein distension, something we would associate with some cardiac conditions, also potentially some chest trauma. Doesn't appear to have that. I'm also going to check to see if his trachea is in line. Maybe suggestive of a tension pneumothorax. So I just want to make sure that it's right down the middle of his throat, as it does appear to be. Okay. After that, I want to see if he has any subcutaneous emphysema. So I'm going to palpate his neck and just see if I can feel any of that. I may palpate across the upper portion of his chest. If he wasn't wearing a sweatshirt, I may go ahead and just kind of lift that up to take a look. But you guys kind of get the idea. Just palpate across the upper chest, see if it happens to be there as well. Also want to know, Jason, do you have any medical alert tags? No bracelets or anything like that? Nothing on his neck or anything along those lines? And the last thing I want to check for is, does he have the presence of a stoma or a hole designed for his breathing? I would have, hopefully found that a little bit earlier during my assessment, but it's always a good time to go ahead and double check that as well. Right? So once I've gotten through the area of his neck, I want to move down and assess the patient's chest. And so again, I'd probably want to go ahead and expose this area, but I'd want to just kind of do an exam to make sure that he doesn't have any trauma. So I'm going to kind of place my hands around his chest here. All right, just make sure that his chest wall is intact. I'm going to have Jason take another deep breath for me just to make sure he has that good equal chest rise. Also looking for paradoxical motion. When one portion of the chest rises, a small segment inside of it may go the opposite direction, suggestive of some multiple broken ribs. Want to look to see if he has any retractions in between his ribs, suggestive of some significant difficulty breathing. Also want to make sure, that again, the chest wall is patent. Just take a good look at it, make sure there's no holes, no bruising, nothing along those lines. So I didn't really find anything in his chest, which is common when we talk about, medically induced chest pain. But I do want to go down to his abdomen, take a quick look at that as well. Sometimes issues with the stomach may radiate up into the chest and cause some pain. So Jace, you having any pain in your stomach?
No.
Okay. So I'm going to go ahead and palpate all 4 quadrants of his stomach just to make sure that he doesn't have any areas of tenderness or rebound tenderness, meaning when I let go, he has significantly increased pain. Want to make sure that he's not guarding his abdomen, which he wasn't as I came up. He didn't grimace or anything when I pressed on it. Again, I want to look for bruising. Also want to look for the presence of potentially a pulsating mass on his stomach. Wouldn't want to palpate that. So again, good idea to make sure that we kind of expose the chest and abdomen, get a good look at those. So as I do that and I go through, I find that I don't really have any, significant physical findings on Jason, which is, again, normally associated with some medically induced chest pain. With that and his description of his chest pain, it's fairly good or fairly safe for us to assume that this is a cardiac-related condition. And because of that, I'd find that some of the medications that we might administer are indicated for this particular patient. So, Sean, what we come up for his vital signs?
I got a blood pressure of 124 over 82.
Okay.
Heart rate of 104.
Okay.
His respiratory rate was at 12.
Okay.
Sats are still about 96, 98%.
Good. Kept that on the whole time. Okay. All right. How about his pupils?
That I did not check.
Fair enough. Okay. And while he does that, I'm going to go ahead and get a couple of these medications because I'm going to give a radio report to the hospital, and I am going to go ahead and request to administer a couple of these. Now, this will depend on whether or not you have some standing orders. And in class, at least at the EMT level, we do allow our students to go ahead and administer aspirin to your patient. Very, very important in the context of a heart attack, and so we'd want to get that on board if that's what we think is going on with Jason. So I would go ahead and open these up. We're using some baby aspirin here, so I'd want to get 4 of these out of the container. Want to hand them to Jason. Very, very important that I go ahead and have him chew these. Now, before I administer a medication, I just want to make sure that I've met all of the rights of medication administration. Want to make sure I have the right patient. Again, that this condition suggests that he is having some chest pain that the aspirin would benefit him for. I want to make sure I have the right medication, that I am holding, in fact, aspirin, what I want to give to my patient. I want to make sure I have the right dose, and while the dose does range from 160 to 325 milligrams for the aspirin, again, the protocol that we use here in class is going to be I'm going to give 4 of them to him. So I want to make sure I give him 4, no fewer, no more than that. I also want to make sure that I use the right route. Medications are designed to be, swallowed or eaten. Some of them are designed to be injected into the body. Obviously, however it's designed to enter in the body, that's how I want to administer it to my patient. And then I also want to make sure that I have the right time. Some medications may allow for some repeat time, and so I may need to give that at very, very specific intervals. I just want to make sure that that interval's been met before I administer it. So, last thing, I want to make sure that the medication is not expired. You guys will find a lot of the medications that we use are in fact, but we use them for training. In the real world, I would never administer a medication to a patient that was past its expiration date. So because I have some standing orders for this, always a good idea for me to verbalize that as a student, that I do have standing orders. I'd go ahead and administer these aspirin to Jason, have him chew them up. I may let him know they're not going to taste all that good, but such is medicine. And so after that, my next step is going to be considering to administer some nitroglycerin to my patient. And in order to do this, I need to make a radio report to the hospital. And so frequently you'll find that we'll do this right in front of the patient. All I'm doing is calling a physician and making sure that, that I may administer a medication to my patient. All right, I've got my radio. I've gathered all of my patient information. Now I want to go ahead and call the hospital. Because this is a request for medication administration during this particular scenario, I want to make sure I give them all the information that I have, even though it will seem to be a little bit long and inclusive. But I need to also make sure that I get a physician on the line because he's the one that needs to hear what I have to say. So I'm going to go ahead and call the hospital. This is Medic Unit 1 to hospital with requesting doctor for medication administration.
Doctor's on standby.
Okay. All right, good morning, doctor. This is EMT Craig, and I'm on scene with an approximately 31-year-old male. Chief complaint today is going to be some chest pain. He's also having a little bit of lightheadedness, a little bit of difficulty breathing. This patient did have a coronary event, actually a heart attack last year, and does compare his current situation pretty much exactly the same as that one was. Patient is prescribed nitroglycerin, does also have a history of hypertension in addition to that AMI. And as far as his description goes, he's describing it as about a 6 on a scale of 0 to 10. Patient does complain of some radiation into the left arm. Doesn't really have any other associated symptoms other than the ones that I already mentioned. Does, as I said before, have a prescription for nitroglycerin, is not allergic to any medications. I have measured this patient's SpO2. It's about 96% right now on room air, so I have deferred oxygen at this particular time. The rest of his vital signs, blood pressure is 124/82. His heart rate is 102, strong and regular. His respirations are 12 and unlabored at this time. Patient's pupils are pearl. His skin is warm, dry, and pink. But with his description of this being very, very similar to his previous cardiac episodes, went ahead and did administer 324 milligrams of aspirin via standing orders, and do want to request the administration of nitroglycerin, up to 3 doses, 0.4 milligrams of each dose sublingually. And we'll just kind of do it or titrate it to his pain. May I administer that nitroglycerin to this patient?
Let's go ahead and go with that nitro 0.4 milligrams up to 3 doses. And with his vital signs, I agree with the holding off on the oxygen for right now.
Okay. Copy that, doctor. You have ordered me to administer 0.04 milligrams of nitroglycerin. I apologize for the error before. And may I give him up to 3 doses of that medication? And you agree with my assessment that oxygen is not necessary at this time?
And we'll see you in room 13.
Okay. Copy that, doc. We're going to administer this medication. We will get him in the ambulance, and our ETA to your facility is about 10 minutes.
See you in 10, sir.
Okay. All right, so now that I've got permission, I've conferred with the physician, I've made sure that there was no discrepancy between what I was requesting and what the physician was ordering. That's why I parroted back what he told me, just to make sure that I'm doing the right thing. I'm going to go ahead and administer this nitroglycerin to Jason. So I want to just go ahead and open this. I'd have Jason lift his tongue to the roof of his mouth. I would do the same thing with this medication as I did before. Right patient, right med, right route, right dose, and right time. This one does have a time consideration, once every 5 minutes as needed by the patient. The doctor did give me permission to do this up to 3 times. So, Jason has taken this before. He's probably prepared for some of the side effects. I may want to mention that it might give him a little bit of a headache. That may be a downside to him, but for us, it tells us that the medication is actually effectively working. So, Jason, I'm going to give you some of this nitroglycerin. This is mine. Should work just the same as yours does. May give you a little headache. You might be used to it, but we're going to administer this, and we're going to go ahead and get moving. We'll get in the ambulance, and we'll start heading towards the hospital. Okay? So I'd go ahead and have him lift his tongue to the roof of his mouth. I'd spray that in there. I wouldn't do it because this is actually a live medication. But after that, we would go ahead and get Jason on our cot, and we would get en route to the hospital.